Good morning, everyone. Just making sure people online can also hear me. Welcome, everyone, to our side event, Pandemic Prevention, Preparedness and Response, What It Means for People Who Use Drugs. I'm Judy Chang, the Executive Director of the International Networks of People Who Use Drugs. This is a hybrid event, so thanks to those joining face-to-face and also online, and there's translations available for people joining virtually in Spanish, French, and Russian. This is a very significant side event for us, as it is the first time a drug user-led network has led a side event under our own name, and it took many years to gain ECOSOC status to be able to do this. We're very proud to be joined by our co-sponsors, INPUD, MENINPUD, NAPUD, Radar, AfricanPUD, EuroPUD, SAMPUD, DAN, and Youthrise, all community-led organizations, and as well as being co-sponsored by UNODC HIV/AIDS section. So today we're launching our new report, Pandemic Preparedness and Response, Voice of People Who Use Drugs. There's copies in the room. And we have a wonderful lineup of speakers who will be speaking to the report and the theme. So the reason we focused on this theme is because we saw the devastating and disproportionate impacts that COVID-19 had on our community, as the impact of the global pandemic intersected with criminalization, poverty, and violence that we experience as a community of people who use drugs. But on the other hand, we also saw how effective our community was in dealing with the pandemic and how much resilience was shown, because we are so used to having to do without and so used to having to support each other with scarce resources. So there are significant opportunities in the coming years to incorporate our experiences and lessons into global decision-making. Global solidarity is key to fighting global pandemics in the sharing of information, knowledge, and resources. And this is the basis for discussions around an upcoming pandemic treaty accord. But in order to be relevant and useful, a pandemic treaty needs to be informed by realities on the ground, by people's lived experiences, including those of people who use drugs. In fact, we arguably have the most to share, as criminalization has always driven us away from formal health systems, whose frailties for the broader public were exposed as well during COVID-19. With a new focus on PPPR and a potential treaty accord, we have the opportunity to critique and shape a new system and framework that is inclusive and values all and sees people who use drugs as experts in our own right. So without further ado, I'm really pleased to be turning to Dr. Annie Madden, project lead with INPUD, who has decades-long experience in drug user advocacy, rights, and research, and who is a co-lead investigator on the report, who will be presenting its findings.
Computer. Hi everyone, my name is Annie Madden and I'm a project lead at INPUD, and I'm also on the research team that has conducted the research behind this new INPUD report that we are launching today. I'm sorry I can't be there with you live to present this, but there are others from the research team that are attending today, and they'll be able to answer any questions you have as a result of my presentation. So here's the report we're launching today. It's called Pandemic Preparedness and Response, Voices of People Who Use Drugs. I have some acknowledgements quickly here around the research team, which was Sarah Meg Davis from the Geneva Graduate Institute, myself and Caitlin Large also from the Geneva Graduate Institute. Also want to thank Judy Chang, Executive Director of INPUD, for her work on reviewing and editing the report, and our Community Research Board members who are listed there, who are incredibly helpful during the research process, and the study participants, of course, without whom we couldn't have done the research at all. So just quick background to the research that underpins this report. Previously, INPUD had done some work early in the COVID pandemic in 2020 to look at the impacts of the COVID-19 pandemic on communities of people who use drugs globally. Those reports are available on the INPUD website in 6 languages. But in and around sort of late 2021, INPUD had received some money to do some more community research on the impact of the dual epidemics, in fact, of HIV and COVID-19 pandemic on people who use drugs. And it was also around the time when the COVID-19 Make It the Last Pandemic report was released. And it was really shown in that the countries had been slow to respond and that international financing had been really too little too late. So, and not long after that, we saw the announcement that WHO, through the International Negotiating Board, would lead a process to develop a new global instrument. It's gone on to be known as the Pandemic Treaty or the Pandemic Accord. So it was in that context that we really decided that we would, this research that we were going to be doing would be great to focus that on sort of INPUD's future advocacy in relation to pandemic prevention, preparedness and response, and wider global health governance matters. So it was a great opportunity for us to look at these issues afresh. We had 4 research questions that we focused in on. So we wanted to understand better about some of the harms and challenges that people who use drugs face during the COVID-19 pandemic. We're also interested in the continuing impacts of living with multiple pandemics on communities of people who use drugs. We're also interested in how prepared governments, civil society and international organisations were to address the needs of kind of very marginalised communities such as people who use drugs during the COVID-19 pandemic. And we also wanted to learn from the pandemic about how to better enable pandemic preparedness and response in the future. We started, in terms of our method and approach, we started with a desk review, looking at some of the academic and grey literature in relation to both the Pandemic Treaty and in relation to COVID-19 and people who use drugs. We conducted some key informant interviews with community leaders from INPUD's regional networks. We took a very participatory research approach, so we did a series of webinars / focus group discussions with a wide range of people who use drugs globally. We, in terms of coding, we used Deduce, which is an online platform, and we had ethics approval through the Graduate Institute in Geneva. In terms of our sample, we had a total of 43 participants. As I say, 8 of them were the key informant interviews, which were done in 7 of the 8 of INPUD geographic regions with our regional networks. And we also had 35 focus group participants across 3 webinars. That was a much wider group of people. You can see there the breakdown of males and females, non-binary and those who decline to identify. A good age range, sort of 70% of our sample is between 26 and 45 and covering off 4 of the 6 WHO regions. Now, in terms of our data and findings, we actually sort of have grouped those into 8 key themes. I'm not going to go into these now in this short presentation, but you will find that each of these areas are covered well in the report. There's a section on each, and so those who are interested, I really commend that report to you to have a look in detail at some of these key issues that affect people who use drugs during the pandemic around economic impacts and police and violence, gender-based violence, accessing services, the key role of peer-led services, issues around harm reduction, issues around digital divide, financing of community-led programming and just thoughts around the Pandemic Treaty generally. What I want to do just for the remainder of my presentation is quickly just take you through the sort of broad conclusions that the report reaches around the COVID-19 pandemic and people who use drugs. So, first of all, our research really, like other research has shown, is that it illuminated myriad weaknesses in the global health system and its ability to prepare for, respond and mitigate a global pandemic. Really, it's fair to say that the social, economic and health impacts have been devastating for a lot of people, for all of us really, but our research shows a really disproportionate impact on those who are already marginalised, and that includes, of course, people who use drugs. As a criminalised and marginalised community, people who use drugs were exposed to some of the worst harms of the pandemic. according to what we found in our research, and that was harm in terms of economic survival, loss of employment and housing, exposure to punitive enforcement restrictions and extra surveillance, increased violence, as I said, gender-based violence would increased, and also a loss of access to essential services. We also found that there were like gendered impacts of the COVID-19 pandemic, and there are important findings from this research around women who use drugs who were hit very hard by the economic impacts, but also, as we have identified in the previous slide, by gender-based violence as well. Also, you know, our research really highlighted that how people who use drugs during the COVID pandemic were not just coping with the COVID-19 pandemic, but multiple pandemics, including HIV, HCV, and COVID-19. And they were often doing this all the while services were closing around them and being suspended and reduced and going online. So these are services that many people rely on for critical services. Despite all of these unprecedented and disproportionate impacts on people who use drugs, what we also found, though, that there was a real mobilization and solidarity and innovation, in fact, among peer-led services and community-led services, and even at the level of peer-led networks on the ground locally. They really stepped up. It was the peer-led services and programs that really stepped up and filled those gaps and addressed people's really critical needs during that time. There were some other innovations that we noted in our research as well, some of the policy and regulatory flexibilities around things like take-home doses for OAT, which previously we had been told were, you know, not possible to achieve or could be very risky. In fact, we found they were highly beneficial, both for the individuals and the wider system. Decarceration efforts, where people were released from prison, including for drug-related offences, and hotels being converted into shelters and housing for people. Some of these innovations and partnerships have, of course, already made the world a better place for the next crisis, but our research shows that there's still much to be done. There's still a lot to do in terms of responsiveness, and in particular in flexibility and transparency and sustainability, and making sure the gains from COVID are not lost, particularly things like changes to policies and practice. We also need to have better financing and resourcing for community-led programs. During the pandemic, we did see some funds being made available for underserviced populations, including people who use drugs, but often donor imperatives, our participants were telling us that donor imperatives are often restrictive and didn't necessarily align with community priorities, and that often their advice as community leaders, you know, they didn't feel it was being heeded, and they were being told that funding needed could only be used for certain things and not things that they felt were priorities or they knew were needed, and peer workers being underpaid a living wage for their expertise. Really, the message from our research is that PPPR and global health governance must take proper account of the human rights and experiences of marginalised communities. We found that people who use drugs do want more meaningful participation in things like the pandemic treaty process and also in wider global health governance processes. The final thing I would say about our conclusions is that we draw this from the universal health care and the idea of putting the last mile first. And our research shows that it really demonstrated that any health system and response that works for the most marginalised, such as people who use drugs, will work better for all and should be the guiding principle for the future of global health governance. My last slide here is the seven recommendations that we have made in the report. Again, I'm not going to go into them in detail, but they encompass things around upholding and enshrining human rights, ensuring meaningful participation of communities, ending criminalisation, recognising community system strengthening as integral to preparedness, financing mechanisms are needed that value community and principles of sustainability, transparency and accountability. We need to end stigma, discrimination and violence against people who use drugs, including gender-based violence, and importantly, around fulfilling the right to health for people who use drugs. All the things that we talk about all the time around comprehensive access to harm reduction services, fixing stockouts, preventing stockouts of essential medicines that we saw during COVID, safe supply, all of the things that we know come together to mean health and well-being for people who use drugs. I'll leave it there. It's my pleasure to launch the report. Hard copies are in the room. It's available online now on the INPUD website in 4 languages. And I'll hand back to Judy now. Thanks for your time.
Next, I'm really pleased to be introducing Professor Michelle Kazakshin, who's the Commissioner for the Global Commission on Drug Policy, and who again has decades-long experience in fighting AIDS and promoting global health as a physician, researcher, advocate, policymaker, diplomat, and administrator.
Thank you, Judy. I am afraid I can't switch on my video. It says I need permission. Anyway, let me start and saying good morning, everyone, and thank you to INPUD, and thank you to the UNODC HIV/AIDS department for the invitation to participate in this panel. We at the Global Commission do welcome very much INPUD's report, your report on pandemic preparedness and response. And I must say, as also a former member of the independent panel on pandemic preparedness and response, I fully agree with the analysis that was just presented. It is absolutely true that the pandemic has upended societies. It has put the world's population in grave danger. And it has exposed, as you said, deep inequalities. Inequality between and within countries have been exacerbated. And the impact, as said in your report, has been most severe on people who are already marginalized and disadvantaged, including people who use drugs. Current institutions, public and private, failed to protect people from a devastating pandemic. And so without change, they will not prevent a future one. And so this is why the independent panel has called for a package of reforms focused on sustained high-level political attention to pandemic prevention, preparedness, and response, new and additional financing, and equitable access to countermeasures. Of most importance, and what I'd like to stress here, is that the system for preparedness and response in the future is fit for purpose. That is, it's equipped to identify and contain pandemic threats so that outbreaks do not become epidemics and epidemics do not become pandemics. But if that is not possible, give maximal protection to societies and economies. I agree with the report's view that the issue of pandemic preparedness and response is not just a health sector issue. It is also a major social and economic issue that requires a whole of society and a whole of government approach. There are several ongoing processes of reform at the global level as we speak. One is the one you mentioned, the negotiation of a new pandemic treaty or convention in Geneva. There's a new pandemic fund, and the board of that fund is meeting next week in the US. And there is a high-level meeting of the UN General Assembly in September. In that context, we at the Global Commission fully support, of course, that people's right to health, including to health countermeasures and right to dignity, must underpin a new transformed pandemic system. Equity must be built from the start to finish, or end to end, in a transformed system. As you know, or may know, the Global Commission has been advocating for 5 pathways of drug policy reform that fully fit in such an approach that places human rights at the center. The right to health as our first priority, and access, universal access to medicines under international control. The second is the right to dignity, as we strongly advocate for decriminalization and actually for the removal of all sentences, be them criminal or administrative, for possession of drugs for personal use. And the decarceration measures taken during the pandemic, which you mentioned in your summary, should be followed by dramatic reductions in unjustified and harmful long prison sentences for often minor drug offenses. 3, the refocusing of law enforcement investments from the harassment of users and small dealers to action against criminals and money laundering that preside to the huge criminal market of drugs. And finally, ending prohibition and moving towards legal regulation of all drugs, since we believe that prohibition is the problem and not the solution. The UN General Assembly high-level meeting on pandemic prevention, preparedness, and response in September this year will provide world leaders the opportunity at a key moment to choose to protect humanity. It is an opportunity we cannot miss. So as we speak, I encourage you, civil society and communities, INPUD, to focus your advocacy efforts on this political moment, including at the civil society hearings next May that will precede the beginning of the negotiations of a political resolution for the September meeting. We as Global Commission stand with you in your fight for the rights of people who use drugs and for a rights and health-based approach to reforming pandemic preparedness and response. Thank you again for the invitation. And sorry that I couldn't switch on my camera.
No, we're sorry about that as well, but we definitely got your message loud and clear. And thank you so much for that message of allyship and really focusing on the key points of the right to dignity for all and a strong call for decriminalization and regulation. Thank you. Next up is Miss Angela McBride, Director of the South African Network of People Who Use Drugs, and she was also a member of the Research Advisory Board for the report.
Thanks, Judy. Just to start off, to say thank you to everyone here, but also to INPUD for making this possible and also for including SAMPUD in South Africa in this. Everyone was caught off guard when COVID hit. It took everybody and through everybody. However, at the same time, it did impact the community that were most vulnerable immensely. Next slide. Yeah, thank you. Some governments, some institutions, and some spaces reacted in healthy and helpful ways. Others went backwards. In South Africa, shelters were opened and spaces were made available, safe spaces. Some of these were safe spaces. Some of these were spaces we could go to and we were welcomed and we were treated like human beings. However, in other spaces, that didn't happen. In some situations, people were used abused and taken advantage of in these shelters or safe spaces. People were told you could access needles and syringes, methadone, and the likes, which was possible in some of these shelters and safe spaces. However, the referral systems and the aftercare systems were not in place. A lot of community-led organizations and a lot of nonprofit and NGOs were the ones responsible for redistributing and reallocating funding in order to allow for the procurement of PPE and other hygiene and health commodities. The impact the response caused was felt across the country, but unfortunately, no follow-through was made available for our community. We already have a very shaky aftercare system when it comes to shelters, safe spaces, and rehabilitation. They were not strong enough and they've never been, and they need some work. However, after COVID-19, we truly saw in South Africa that this needed some work. If we are honest, this needs to be improved. Unfortunately, in some cases, these safe spaces became a space of exploitation. Nonprofits, NGOs, and community-led organizations were refused access, even though we had reallocated funding to provide methadone, needles and syringes, as well as other needed PPE. We were refused access because in the end, we realized and we found out that these were spaces where people were being taken advantage of. Women were being sexually harassed. People were dying from preventable, I get slightly emotional. People were withdrawing, and as a result, with the lack of services available, with the lack of support available, humans died in these safe spaces. There are a lot of human rights violations that were taking place. But that wasn't even the start, and that wasn't the end either. In addition, our government did try. They did try and address COVID-19 to the best of their ability. However, we realized very quickly that criminalization causes harm. In South Africa, cigarettes and alcohol were prohibited during COVID. It took a number of weeks. It was a control mechanism on and off 2-3 weeks. We were told there are no cigarettes allowed. There is no alcohol allowed. People from a space of privilege would stock up on cigarettes, stock up on alcohol, or import from across the country and the world and sell these cigarettes and alcohol for extremely high prices, exploiting humans who needed and who wanted to access this. We noted in South Africa that this is a perfect example of why criminalization doesn't work. Because people didn't stop smoking, people didn't stop drinking. In fact, we just found alternative ways. But unfortunately, these alternative ways also caused a lot of harm. People were smoking unregulated cigarettes. People were drinking and creating and making their own alcohol. So much so that children still to this day are dying from alcohol poisoning. But alcohol that was made at home. Even though we went through this, even though this was acknowledged, that criminalization of the cigarettes and alcohol did not help. It did not stop people from drinking or smoking cigarettes and drinking alcohol. It's still stuck. In South Africa, we sat every week, every 2 weeks, waiting for that Sunday afternoon, where we would sit and watch our president say to us, oh, you can drink this week, or no, you can't. Unfortunately, again, like we said, people had to make plans. People who had access could make a plan, but people who couldn't. There were people in our community who were buying cigarettes one cigarette and smoking it between 4 or 5 people in the middle of COVID, this was problematic. But the justification was, if you're smoking, you're exhaling, and that causes COVID. Unfortunately, the approach towards this was counterproductive and did not help. Next slide, sorry. Thank you. NGOs and service providers responded to the best of our abilities. By reallocating funding, we were able to provide PPE and wellness packs. Unfortunately, this couldn't go too far. And we did as we could, and we do as we can. But yet, the criminalization of people who use drugs, the targeting of people who use drugs, and the general violations that came from these these restrictions impacted our community. By looking at the criminalization of cigarettes and alcohol, we can truly see the impact that criminalization as a whole has on our community. If we can learn and take anything from this pandemic, we need to learn that criminalization and isolation and exploitation of our community is not helpful. In fact, it just creates more harm. Next slide, please. Police brutality and forced relocation was evident. And when shelters closed, there was no aftercare, there was no thought. And the response from our governments, officials towards the country's people was one of enforcement and not support. Even the words within themselves, enforcement, stood out. Health was not the focus. The well-being of our community was not the focus. It was control. That's not to say that our government didn't try. That's not to say that our government didn't attempt to make life better. However, their approach could have been better. One of the lessons learned was the need and the importance of unrestricted funding, or at least funding to respond to pandemics and situations like this. Community-led response funding ensures that we can procure PPE, we could procure emergency methadone and the likes to support people in these shelters. Government needs to take ownership, not only of the harms that they've caused, but also of the power that they have. Now, going forward, we need to look at government funding of programs, of needle syringe programs, of procuring and disposal of needles and syringes, but also of providing a supportive space. There were some shelters, there were some spaces that were comforting, kind, and supportive. But at the same time, there were ones that were just perpetuating the harms and the pain that doesn't need to be there. Criminalization does not work. If anything, all it does is make life harder. In closing, I just want to say thank you again for everyone for input, for this opportunity. And to say again, criminalization causes harm and nothing about us without us. Thank you.
Thank you so much, Andrew. It's really important for us to hear about the experiences of community at the country level, and really looking forward to working together and disseminating this report and bringing these insights to the negotiation process. Really also want to congratulate INPUD for being such a critical resource for people who use drugs during the pandemic and providing support to communities that may otherwise not have gotten any support. And, thank you for really vocalizing it and making that visible. So next, I'm very happy to introduce Ms. Fariba Sultani, Chief of the HIV/AIDS section of UNODC, who are a longstanding partner and ally of INPUD, and she'll be bringing her decades-long experience of HIV on these lessons to keep in mind for PPPR.
Thank you very much, Judy. Thank you, Angela, for your intervention here. And really thank you, INPUD. Thank you, Judy, for inviting us to the side event and for all your efforts. I would also like to thank all the regional and country networks who have been part of this side event. And also I would like to congratulate you for this really very important publication and this community-led research project. It's very important, as you said, for the community to have a voice and to bring the what they went through this devastating time of the pandemic, and to show how the pandemic, it was devastating for everyone, but it was even worse for the criminalized, marginalized population, like your population group, which I'm really it's amazing to have this report. You know, we will work together to really advocate, disseminate, and use it for in the pandemic preparedness response developments that are currently ongoing, as Professor Kazakhstan just mentioned. And it is really vital to hear from the community about the impact of COVID, because it's not just the COVID, but it's the several pandemics going on at the same time, and how it's continuing to affect the people who use drugs. And we fully agree with all the recommendations made in this publication, and we will, help, as I said, to disseminate, to make sure that all the recommendations happen, they're taken on board in the different countries. I would like to just take this opportunity to share with you some of the work that we actually did together once the pandemic hit. The second slide, please. So one of the first things that we did, we organized 2 years ago on the occasion of the CND, together with the International AIDS Society, WHO, of course, UNAIDS, and our partners INPUD, we organized a virtual consultation to provide a space for the academic world and the community of people who use drugs to express their perspectives on the most urgent and crucial issues regarding the impact of COVID-19 pandemic on the delivery of harm reduction for people who use drugs, including those who are incarcerated and are in prison. And I really am very proud of this scientific consultation that we organized, because I think this is the only space where the voice of the community is brought to the plenary. And it is a very, very important statement that comes out of this statement. And in the CND plenary statement, Professor Adiba Kamarul-Zaman, who was then the president of IAS, urged the CND delegates to ensure that the lessons learned from the hardships of COVID should not be forgotten, and indeed can contribute to stronger human rights protection and improved health for all. I would also like to highlight 2 particular recommendations that came out of this consultation. One was that COVID-19 adaptation in the delivery of harm reduction, particularly the expansion of take-home opioid agonist therapy, which in many countries seemed like an impossible task, actually was implemented, and they saw there's nothing wrong with it, and it actually works, and it helps the communities. And the second thing, and the peer support treatment for HIV, hepatitis C, they are proven to increase acceptability and uptake of services and should remain in place. So this is a very, very important take that I think it's also in your recommendations. And the second thing, which is very, very important, is the greater involvement of the communities, to hear their voice and to be a part of the COVID-19 response plan, not only, but in all the different country-based response plans that are ongoing to increase acceptability, access, and retention in services, because only the community know what works for them. So they need to be a part of this discussion. And what you mentioned is very important, that we also got the inputs from our country colleagues, that the community proved to be so effective as first responders. You were there, peer-led interventions really affected how this pandemic affected the communities. And to bring the commodities to the streets, to the peers. And this only proves further evidence that we have to support the 30, 80, 60 targets for community-led involvement in the HIV response laid out in the Global AIDS Strategy. Slide 3, please. Thank you. So following these recommendations, we have together with WHO and UNAIDS that details the experience of lessons learned from COVID-19 with respect to the delivery of OAT, needle syringe programs, and intervention for the prevention of opioid overdose-related deaths with naloxone. Most of countries surveyed for these reports are developing plans to maintain OAT, and this is what we're promoting together to ensure that this is happening and it doesn't go back. The report was also accompanied by an advocacy brief that described the results of the adaptation in coordination and delivery of opioid agonist therapy taken by some countries during the COVID-19 pandemic to ensure the continuity of services, essential services for people who use drugs. It makes recommendations on how countries can capitalize upon the successes achieved through the introduction and extension of take-home OAT and other flexible approaches to OAT. And I think my colleagues can put this in the chat for the links to these documents so that everyone has access to them. The next collaboration that we did was with Harm Reduction International in issuing a technical brief, that's the next slide, please, on tailoring vaccination campaigns and COVID-19 service for people who use drugs. This guide aims to support harm reduction services in further realizing their role as an essential public health service by drawing on their unique expertise and position to strengthen national vaccine efforts. So this is another publication that we have been doing. So I've got 1 minute, I know. So in closing, I just want to say that in my 20 years, as Judy mentioned, working actually on harm reduction, I realized that more and more the international community, very late on in the day, but now they're recognizing the importance of community-led responses, that the community's voice, leadership is essential if we want to deal with any pandemic. We are dealing with the HIV pandemic for 4 decades. There are other issues that come up. So we really need to make sure that we're in whatever we are doing, from the planning, from the implementation, from the evaluation, monitoring, we have the communities on board and leading in these efforts. And that not only in these, but also in the work we're doing for legislative change, for the policy work that we're doing, it's essential to have the voices of the community. I thank you again. And yes, thank you.
Thank you so much, Fariba, and thanks for your strong message on meaningful involvement of people who use drugs. INPUD, we really do appreciate the partnership with UNODC, HIV/AIDS section, and we saw that very early on in the pandemic and working together on briefs and trying to, make sense of all the chaos that was at the beginning of the pandemic. So last but not least, I'd like to turn to Mr. Anton Basenko. He's a program manager of EATG and is also chair of the International Network of People Who Use Drugs, as well as a member of the Research Advisory Board.
Yeah, hi, hello everyone. I think I have not so much time, right? We just have 7 minutes, if I'm correct, to the end of the event, correct? Yeah, so I'll try to be really quick. Yeah, so as Judy mentioned, I have two hats on my head. So as an INPUD chair and representing the voice of the Eurasian network of people who use drugs, so I will speak on behalf of the Eastern European Central Asian region with a lack of harm reduction programs, region with a high level of stigma discrimination to people who use drugs, with quite weak social and medical systems, with of course with difficult access for people who usually left behind or marginalized as people who use drugs. But also I will bring some perspective of the European AIDS Treatment Group, the network which represents the voices of people living with or affected by HIV, and we're based in Brussels. So I will try to bring this, let's say, WHO European region perspective in all this conversation. So but I'm Ukrainian, and I'm, of course, person who uses drugs, one of the first substitution therapy patients in Ukraine. And next slide, please. Of course, I remember very well what's happened with when COVID appeared. No one, I mean, governments and no one were really prepared in a sense. I mean, we as community, we are in a certain, we live in a certain, you know, survival mode, and as I said, war on drugs mode. So we kind of always mobilized. But we always, when such situations happens, we need some kind of, you know, resources and opportunity to raise our voices and to find solution for the issues. But what kind of issues we observe? I do remember the situation when transportation was completely stuck. You can imagine in such a big city like Kyiv, 4.5 million people. It's a big territory, and people cannot reach to harm reduction service point or opioid agonist therapy sites. It was hundreds, crowds of people near the premises of opioid agonist therapy websites because it was impossible to enter more than one person in the premises at the same time. So all these things, and of course, people were losing, you know, work, losing their linkages and contacts, and of course that panic around at that time, no any vaccination or proper treatment. And as I said, you know, as a community, we usually left outside of like normal access to health systems. So all of that, of course, created lots of issues, but we always trying to find some solutions. And actually what we can see from Annie's report, the COVID pandemic really brought us these things like, you know, innovations, online approaches, all these situations with, you know, extended take-home dosages or alternative ways of delivery of medication, etc., etc. So next slide, please. But and you know that all this situation with COVID, of course, brought certain lessons learned to us, that the inclusion of people, meaningful inclusion of people who use drugs and their voices into decision-making process, or in the development of these solutions to these situations must be included, of course. And we definitely realized, and we, let's say, we were better prepared when the war came into my country in Ukraine. You know that there is a full-scale Russian aggression and invasion. And good example, for instance, of course, you can see that the problems mostly were similar. So it was difficult access to OET and harm reduction services, stockouts of essential medicines because logistics chains were broken, huge internal displacement of people, as well as you know, streams of fleeing people fleeing from Ukraine as refugees to EU countries. But given these lessons from COVID-19 and our involvement in our collaboration with Ministry of Health. So during the first days of the war, Ministry of Health immediately approved the act which allowed take-home dosages up to 30 days. So it was the real example how properly, timely can be reaction of governmental institution based on the request or an advocacy ask of the community, and with the full support. So that's why inclusion is important. But also, as I said, of course, time is very important. We cannot wait a month, year until some solution will be found. This is really ad hoc situation here and now. People need help, and our lessons that we really rely on a timely and immediate response, as well as we really should give to the people what is needed. We know that in COVID, as well as war in Ukraine, basic needs, things like house, living, houses, food, really basic needs that is what is like really needed. And you cannot, when person is asking you for some help, you cannot say, sorry, I have only syringe for you, but I cannot give you anything else. So that's why all these things like shelters, which we started to use from COVID, and of course in the war, it helped us a lot. We just extended the network, and maybe we a bit adjusted the approaches, but still all these things like food kits or some kind of hygiene kits, etc. It's really what is saving lives of people at this moment. And of course, we're always talking about resources, and it's very, very good and important to see that such a big donors like Global Fund, for instance, with C19RM mechanism, or other donors like AIDS funds, etc. So they created these emergency funds. So this is really so this practice which started with COVID, but in fact with war in Ukraine it continued and even increased. This is also good lesson learned. Next slide, please. As well as we can say that, of course, we cannot separate, things like pandemic prevention, preparedness, and response to drug policy, because, of course, when it's coming to people who use drugs, any response is based on the existing policy, drug policy in country. So that's why it's impossible not to include the drug policy approaches and reforms into the PPPR agenda. So that's actually briefly all from my side. And of course, as a person from Ukraine, I would like to take this opportunity and to thank everyone for your people, your country, your organizations, for daily support of Ukrainians and key populations and communities in my country. Thanks a lot. Slava Ukraini.
Thank you so much, Anton, and especially for being here during such a difficult time. And we are all standing in solidarity with you and your community. Really important message at the end of the day, it's about people's lives. There are people, we're struggling to survive, especially during emergency situations such as war and crisis. And unfortunately, it feels like sometimes we're, the last ones to be supported. Thank you, Anton. I know we're just out of time. We're going to see if we have space for questions, because we have been joined by Meg Davis, who is also one of the lead investigators on our report. So just checking in either face-to-face or virtually if there are questions specifically to do with the report that Meg can answer, as well as the pandemic treaty/accord. Thank you for joining us, Meg.
It's a pleasure to be here. I've been trying to reply to some of the questions in the chat, and I saw there were some questions about the recommendations, which I would refer everyone to the actual report, which lists them in some details. I think they're pretty well captured in the report, so I'm not going to try to summarize them now since we're over time. Thanks.
Thanks so much, Meg. Okay, Matt.
Yeah, thank you very much for this really important piece of work. I think it's great to see INPUD looking forward to the next pandemic, and not like governments have done, sitting there waiting, hoping that these things won't happen again. I think the UK has a really bad example of what happens when you don't prioritize harm reduction. Because harm reduction wasn't made essential, we saw needle and syringe access reduced. We've seen needle and syringe uptake reduced by 25 to 50%, and that hasn't gone back up again since the pandemic. One of the few examples of where drug users actually implemented needle and syringe programs in our own communities, then we made a difference. But now the whole UK is struggling to get NSP back up again to the old 30% coverage level. And it shows that when governments don't prioritize harm reduction, we teach people who inject drugs that harm reduction isn't important. They go back to sharing, reusing, finding things that we've spent so many years trying to overcome. And I think it really highlights why community-led is the solution.
Thanks, Matt. So that was a perfect message to end on. We are over time. I just really want to thank everybody for joining us, both virtually and in person, and really encourage people to go to our website, read the report, and disseminate as much as possible. Thank you so much.
Thank you.
Thank you, everybody.
Thank you. Congratulations.
Buongiorno.